Good evening. My name is Mary Lucy Anciolo. I hope all of you can hear me. And I see I have Hannah M. Renstein here on the webinar so far. What we're going to be doing tonight is we are going to be going through professional responsibility. And let me make sure I get this recorded before I go too much further. Yep, it's being recorded. Life is good. Okay. So again, my name is Mary Lucy Anciolo, and I'm the administrative instructor for Therapy Team Educational Services. We've been doing this course for a really long time. This is the first time most of you have heard me this session. Back in the day of when we did the live courses, I would be the person always doing professional responsibility and legal and ethical concerns and test-taking skills. And for this session, I'm going to be doing professional responsibilities, which incorporates some of the legal concerns that we see on the content outline for the National Physical Therapist exam and the National Physical Therapist Assistance exam. If you have any questions, just raise your hand, just do a hand raise, and when I recognize that you have requested to ask a question, I can unmute you to ask the question, and we can go from there. It looks like a few more people have joined in, so let's get started. Professional responsibility. Here we go. First thing we're going to talk about are standards of documentation. And one of the things you need to familiarize yourself with is the American Physical Therapy Association's physical therapy documentation, the standards of practice, the documentation of patient-client management. Pretty much any exam question that's going to be written is going to be from the APTA guide for documentation of patient-client management. So if you do not have this document, you can get it on the internet, that wonderful thing. Just type into your browser http://www.apta.org. If you can't get all of this, just type in APTA Practice Documentation Patient-Client Management, and it should take you to this PDF to download. That's what I normally do when I'm looking for things, rather than the entire web address. And read it. Be familiar with it. It's a fast read, 30 minutes, but be familiar with it. Now, why do I say that? I hate documentation. Most physical therapists and physical therapist assistants hate documentation, but documentation is pretty much your best friend. If you are the lead therapist, the lead PTA, you're the PTA and you're working with a PT, you're a PT, you're working with a PTA, all of that, the medical record, the documentation serves as the record of the patient-client care and their status. So whether you're using paper documentation or online documentation, as most people are these days, you can go to that patient record. You can easily review what's been written, the outcomes, the management, the outcomes. It allows you to communicate with each other, as well as for insurance companies, physicians, anyone else, OTs, speech therapists, anyone else who's working with that patient can look at your notes and find out exactly where this patient is. When we look at it from a physical therapist, 30,000-foot level, the quality of your documentation really says a lot about how good of a therapist you are. And sometimes people say, well, I'm a fabulous therapist, but I'm a horrible writer. Well, you need to become a better writer to really convey what your thoughts are, what your treatment plan is, and what you're doing with the patient, your unique body of knowledge, and the services that you're providing. In some areas, it serves to demonstrate your compliance with federal, state statutes, payer, and local regulations. While this is an exam of national practice, sometimes at state level practice, if you have supervision requirements, for example, you can show that in your documentation to show that you've complied with that. It gives a historic account of the patient-client encounters, that there has been appropriate utilization, not overutilization or underutilization, which third-party payers will look at for reimbursement, and might also for policy or research purposes. Oftentimes, documentation is what's used for retrospective studies, research studies, to look at outcomes and not just the progress of the therapy, but whether or not the therapy has been effective or not. So outcome analysis. So researchers that you don't even know about may have access to your documentation after the patient care is finished to look at whether or not the care was effective. So a documentation really is your friend. Documenting evidence-based care. So this is something that, 2017 is incredibly important. But before you can document evidence-based practice, the therapist must first know how to integrate evidence into clinical practice. So this is where evidence-based practice comes with documentation and the National Physical Therapist exam. The National Physical Therapist exam, as I'm sure you've reviewed with Tim, is very much a clinical exam. It's about, do you know how to practice physical therapy in the real world and apply all of that knowledge from school. In school, you talked about evidence-based practice endlessly. So now with documentation, therapists can show how evidence-based practice is being put into practice, and you do that through your documentation. So number one, by documenting tests and measures that are valid and reliable for diagnostic and or prognostic information. So you write down what tests you've done, how you've done them, what the results are. Two, through the use of standard outcome measures, which are an effective means of evaluating and communicating changes in a patient-client's impairments and or functional level. Three, by selecting and implementing an appropriate plan of care and interventions treatments based on available research or clinical guidelines that reflect patient perspectives and preferences and their influence on the plan of care. So through tests and measures, standardized outcome measures, and then tying it all together in your plan of care, that's how you're documenting evidence-based practice. And that's what other therapists can see. If you're working PT, PTA, you're working with the other discipline, they can see it. OT can see it. Speech, nursing can see it, depending on your care setting. And that's how they know, social work can see it, how they can know and communicate to the patient's family, how physical therapy is assisting the patient in getting better. Try that one. Initial examination evaluation. So when you're looking at documentation and you're putting it all together, the first place you start is the initial examination and evaluation. So who can do this? This must be completed by a physical therapist. Sometimes you'll see things in practice questions, how the physical therapist has asked the physical therapist assistant to do the data collection component of the initial examination evaluation. Under this guide for documentation, that's not allowed. Everything in the initial examination evaluation must be done by the physical therapist. And it's generally done in one visit. One wouldn't be done in one visit if the patient can't tolerate it in that one visit. So it would be the needs of the patient or the physical therapist. So I guess the physical therapist could get interrupted, but pretty much as a PT, your goal is to get this done in one visit if at all possible. And documentation elements for the initial examination evaluation include the examination, the evaluation, the diagnosis, the prognosis, and the plan of care. So those of you who are physical therapists, this part is 100% your responsibility. You have to lay this out because everything after this is based on this initial visit and your findings of this visit, your plan of care that you set in this visit. So if you're working with a physical therapist assistant, it better be here because he or she is going to be looking at this initial examination evaluation very carefully for guidance as to what to do. Then we get to the examination. The examination component includes the patient-client history, so their medical history. Have they had surgery? What are any other diseases, conditions that would be relevant for the physical therapist in designing the plan of care? Any limitations that the patient has that could affect how you proceed with the plan of care. The systems review going on here. And then findings from various tests and measures. What are the relevant tests and measures in this patient? Are you doing cardiac tests and measures, neuro, musculoskeletal, any other tests and measures? What are those tests and measures, and what are those findings? So you're putting them clearly and completely, what you've done and what your results are. And then the PT uses this information to evaluate the patient-client and determine the diagnosis, the prognosis, and the plan of care, including the goals and any selected interventions and discharge planning. So let's get to the history. The history is a collection of information that can be gathered through the patient, client, or the family caregiver through their interviews, and it will include a review of past and current medical and social information. So their medical diagnoses, their surgical history, previous and or current interventions, both surgical and physical therapy, list of current equipment, environmental modifications and medications, previous clinical tests, x-rays, CAT scans, etc., and the general review of current health status. So you have to include all of this in the history. Most of this information you can find in other parts of the medical record, and sometimes you'll find out this information from the patient or the family. And then for pediatric patients, the medical history might include history of the mother's pregnancy and complications, if that's relevant, the birth history, the neonatal complications, and the age when developmental milestones were achieved. So we're seeing this in the NPTE. A lot more information is necessary for the pediatric patients. So they're getting more detail on that. That's a trend we have seen. That's a trend we expect to continue even more in the future. The social history may include information on the patient's client's pre-morbid and current living situation, their education work status, cultural preferences, including preferred language, the previous level of function and comorbidities that could affect the rate of recovery and or rehabilitation should be included. So with this slide, I want to take a second to talk about language and translators. You should almost, unless it's an absolute emergency and no one is available, you should not use family members for translation. And we've seen practice questions and other questions on the exam about preferred language. You know, it's never, the exam might not, it's unlikely the exam is going to have something about Spanish. You can always find a Spanish translator. Maybe not always, but pretty close. But what if someone is from somewhere in Asia or Africa? The translator is just not that accessible. It's not a language that you see in your community on a regular basis. And people are saying, well, the family. There are a variety of services. If you're in a larger facility, you probably have a phone number you can call for a translation service that has a whole list of languages. And even if you're a smaller facility, you should have some sort of subscription to one of these services for languages that are not as common. Only when you can't find that language should you be using a family translator, because you can get in problems. Oftentimes they'll say, oh, use my kids. My kids speak English and the native language. Well, that's possibly true, but they speak usually household, the household version of that language. When we start getting to medical language, they don't know those words. And when you get into also the issue of comfort, does grandma have the comfort level of explaining all her medical details through her grandchild? Maybe, maybe not. There might be some questions that would be highly personal, and you may not get the accurate answer when you're using a family member. So for all of those reasons, it's really important to use a non-family translator whenever possible. For pediatric patients, okay, so for pediatric patients, the social history includes information on the family. So it will include parents, guardians, caregivers, siblings, anyone who lives in the home and or is important in that child's life. The family history can include the resources, the priorities, the needs of the family, information on the child's activities, routines, whether or not they go to school, their daycare, their interests, anything that's relevant to what essentially their activities of daily living are, school, community activities, play, leisure, recreation, socialization, any sports they may play, any play groups that they go to on a regular basis, all of that would be included for pediatric patients. On the other end of the spectrum, skilled care facility residents. Just like with children, you can have communication issues that restrict the information obtained in the patient interview in this setting. A patient history may be gathered from hospital discharge summary, current and past facility assessments, a previous MDS, and the nursing consult section of the patient's medical record. So when you're doing that initial evaluation examination, it's really important that you give yourself the time to go through the patient's notes. If they're in a skilled care facility, just like it would be if you were dealing with a pediatric patient, talking to the family member and other caregivers. So with residents of skilled care facilities, the PT should review documentation of previous functional maintenance programs or restorative nursing programs, as this will alert you to the understanding of the patient's prior functional level. Because with all therapy, the goal is to return the patient to the previous functional level. So It obviously means that you need to take a few moments to look in the medical record, talk to family, talk to caregivers, to find out what that previous functional level is. And because in the design of your program, that's where your goal is going to be, if it's at all reasonable. So the therapist, through that records review, it's important to have an accurate social history, anticipated discharge disposition, including current and potential support structure available upon discharge. Ask the family, what's reasonable. Back in the day when I did the live class, I'd tell a lot of war stories. So my current war story is I have a family member who went to the hospital this summer, and I talked to the social worker, and the social worker says the physical therapist is recommending skilled care facility. And I said, well, why? And it was kind of like, well, she's old. And it really was, they hadn't really talked to me, and they hadn't talked to other family to determine that now there's plenty of resources that this person's not going to go to a skilled care facility, and that family member did not go to a skilled care facility because there were other resources. So before making your conclusion, make an effort to talk to family to find out what resources are there. And just because someone's old doesn't mean they're going to a skilled care facility. There's a whole bunch of reasons why they might go to a home of a family member or their own home with caregiver support. But it's your responsibility and your obligation really to find that information out, because that's going to help you design the goals to get that patient ready to go to that appropriate care setting. Systems review. A systems review is a necessary component of the initial examination. It's a brief or limited examination of the anatomical and physiological status of the cardiovascular, pulmonary, integumentary, musculoskeletal, and neuromuscular systems, and the communication ability, affect, cognition, language, and learning style of the patient client. This is also going to take time, and this is with the patient. This is going through these elements to make decisions about where this patient is status-wise and what the rehab potential is in these areas, because this will help you determine the conditions that may affect the chief complaint. For pediatric clients, the system review may also include consideration of the child's safety and well-being, nutrition, behavior attention, and self-determination. And we're back to tests and measures here, but now as its own individual component. Using the information from the history and system review, you determine an initial hypothesis for the diagnosis. So you've done your system review, and now you're like, you've looked at the medical record. So now it's, what tests am I going to try? And you can change this up. You might decide you want to do one sort of line of tests, and then as you go through it, you're thinking maybe a different set of tests. And this is something that's very common in the questioning on the National Physical Therapist exam, is what set of tests might be best. And that's part of your analysis within the components of cardiopulmonary, neuro, musculoskeletal, etc., to determine what tests you're going to be doing. And then when documenting these tests and measures, you need to clearly identify the specific tests and measures and any associated finding or outcome. And when we're going back to evidence-based practice, the PT should rely on standardized tests and measures that quantify or measure what is being tested. The more standardized you can get, the more numeric you can get, if you will, the better it's going to, the more it's going to help you analyze this patient. And now we finally get to the evaluation component. It's the thought process that utilizes the information from the examination, where the physical therapist considers all the data and findings gathered from the examination in collaborative decision-making with the patient client. This process results in the documentation of such items as impairments, activity limitations, and participation restrictions. Now, you can use a whole bunch of different formats. If you're still on paper and pencil documentation, paper and ink documentation, you might have one flow of documentation. If you're in online documentation, as most organizations are, you can have a problem list, you can have a statement of assessment. You might go through a lot of boxes where you just check off what the right answer is. You might have some choices, including cognitive factors, comorbidities, social support, all of those factors. In all cases, though, the record should convey to the reader what examination factors are relevant to the current complaint, and that then result in the physical therapy diagnosis and the prognosis for a functional outcome, at the conclusion of physical therapy services. Then we get to the diagnosis. This is it. This is the end result of the examination and evaluation process. Here, the PT identifies the discrepancies between the level of functioning that is desired by the patient-client and the current capacity of the patient-client to achieve that level. That is why physical therapy diagnoses are typically made at the impairment activity and participation level. You're going to do this in the form of an ICD code with the G code modifier that reflects the result of the examination and evaluation process. As you should know, the IDC code is everything. If you miss this code, you get this code wrong, things don't go well. What your reimbursement may not be what you need for this patient. Also, if you then get audited and the code doesn't really match what you've done, it could put you at risk of a denial. The prognosis, it's your professional judgment, the PT's professional judgment concerning the patient-client's predicted functional outcome and the amount of time to get to that outcome. The PT is also expected to differentiate between the patient-client's medical progress and the rehabilitation progress. So earlier in this process, you went through in your initial examination evaluation, what are the comorbidities? What is the patient's current previous medical and surgical history? What limitations do those place on this patient's rehab potential as opposed to their pure rehab potential? So for pediatric patients, the prognosis is developmental based and should document the clinical reasoning that supports the stated prognosis. Plan of care. Documentation of the plan of care includes the following components. So there's 5 of them here. Your goals stated in functional, measurable terms that indicate the predictive level of improvement in function. These goals are made in collaboration with the patient-client and other appropriate stakeholders. So in the case of pediatric patients, the parents. Number 2, a statement of interventions, treatments to be provided during the episode of care. 3, the duration and frequency of service required to reach the goals. 4, anticipated discharge plan, which may be part of the prognosis or written separately. And 5, the physical therapy plan of care for a child from birth to 3 can be embedded in the IFSP. The plan of care for a child of school age, which is 3 to 21, can be embedded in their IEP or documented in a 504 plan as a supplemental service to support modifications and adaptations within the school environment. In both early intervention and school-based programs, the plan of care is developed through team collaboration, including the family, when appropriate the child, as well as the classroom teacher. So all of these elements and all of these individuals work together to develop a comprehensive plan of care to help the child progress in the classroom environment. Goals. The physical therapist will develop goals with the patient-client and or family caregiver at the onset of care. Goals are a description of the functional changes they hope to achieve through physical therapy services. Though dynamic, the statement of short and long-term goals should provide the foundation on which the plan of care is directed. So now you have the plan of care. Now you're working it. The physical therapist, the physical therapist assistant, you're working the plan of care. You're giving the treatment. You're working towards your prognosis and the patient's rehab potential. So as the plan of care progresses, the PT can demonstrate progression or lack of progression towards the expected outcomes and discharge plan through updates, changes, deletions, and additions to these initial goals in subsequent documentation. So you go through week 1. Things are going well. Week 2, a little bit of a plateau, but still some progress. Week 3, patient's not making any progress. Well, now as a physical therapist, you have to decide what you're going to do. You got to make a change because you have to show progress every week. So maybe you're going to change the plan of care. And okay, you're going to change the exercises, you're going to change the frequency, whatever it is, you make those changes. You do that to your documentation. You communicate it to the physical therapist assistant or whoever is working with you to provide the care to this patient, and you proceed. But maybe you say, this is as much progress as this patient's going to make. Then it's time to discharge. So then you're going to document your discharge plan and communicate that to the relevant parties and arrange for discharge. Back to goals here. They can be written to address impairments, activity limitations, participation restrictions, and prevention. PT goals need to be objective. So a few moments ago we talked about how tests and measures need to be objective. They need to be numeric. The more objective you are, the better. so must your goals be. And that you're going to be measuring them every time you reevaluate the patient related to the impairment, the activity limitation, etc. Now, to support the medical necessity of the services, PT goals need to be stated in functional terms related to the patient-client rather than the physical therapist. So the goals have to be quantifiable, numeric, and you need to keep showing that you're making progress to them with every visit and definitely every week. Otherwise, you have to make modifications or discharge the patient. So then we come down to short and long-term goals. Your long-term goals are the ones that you developed at the beginning of your plan of care, the day you did that initial examination evaluation. And these are what you're setting as the criteria for discharge. They are functional. They need to be data-based and coming up with a date that you anticipate having reached your prognosis, your long-term goals. Then there's the short-term goals. They are the ones that evaluate the effectiveness of the interventions. They might be daily, they might be weekly, but they're definitely short on a time basis. They don't have to be functional, but they're monitoring the little incremental baby steps of progress. If a reviewer comes in and looks at your documentation, they're going to look at your initial examination evaluation. They're going to look at your plan of care. They're going to look at the notes for week 1. And what they should see in that week 1 is the progress documented clearly, objectively. They don't have to be functional, but pretty clear that you've reached the short-term goals for that week. They go look at week 2, same thing, a little bit more progress, 3, 4, 5, 6, 7, 8, however many weeks you have. And whenever your last week of therapy is, they should be able to go back and look at the long-term goals and see that the patient made these incremental steps through the short-term goals all the way to reaching their long-term goals. That's what's important and relevant. And that's what a reviewer, an insurance company is going to look at. A peer reviewer, someone who's doing some sort of quality check on your services as you get into practice, they're going to be able to see that you have set up the patient for success, you've done a quality examination evaluation, you've set appropriate, attainable goals, you've documented the progress to the goals, and you've had success. So here's sort of a description of the planned treatment that includes the following factors. The patient-client status, including physical, cognitive, and emotional factors, any barriers that might be there, their discharge plan, whether or not additional staff, either PT or PTA, will provide some of the interventions during the episode of care that needs to be documented. If you're in school-based or early intervention, the PT plan is incorporated into the child's general term intervention plan. You're going to see progress to those goals. If you're in a skilled care facility, the PT plan is incorporated into the patient's individualized interdisciplinary comprehensive care plan that reflects problem areas documented through data obtained on the MDS. The therapist needs to initiate and document patient and caregiver training if that's needed, especially if there's going to be a discharge, in addition to providing the results of the initial examination to the interdisciplinary team. So, when a physical therapist is providing care in conjunction with a physical therapist assistant, the documented plan of care should be a clear communication tool for coordination of care. It is this documented plan of care, along with any verbal communication that you make, that guides the PTA in following the therapist's plan during the episode of care. But it's really important as we work in larger organizations, we have more an expectation of treating more patients per day. Everyone has a good memory, and everyone has a horrible memory all at the same time. You might remember pieces of the puzzle, pieces of the plan of care, but no one remembers everything, which is why it's very important as a PT that you document everything for the PTA to go back and reference during the course of treatment. Because over the years, I've talked to PTs and PTAs. In some facilities, you're doing 30 people a day. As I just said, people remember everything, and they remember nothing. That's what documentation is for. Discharge planning really starts with the first visit. So when you're setting up your initial examination evaluation, in your documentation, in the back of your head, in your plan, you're always thinking about where is this patient going to be on the day of discharge? Are they going to a long-term facility? Are they going to be going to home health? Are they going to be going to outpatient? All of those things. And as you're writing your documentation throughout the course of therapy, keep this in mind who your audience is. Who's going to be that next reader of this documentation? So just like when you were on that first visit, that first day, and you're looking at the notes from the hospital, you're looking at nursing notes, you're looking at school notes from the previous school year. They wrote those notes for you. Now you are writing the notes for the next physical therapist in this patient's care plan. Or even if you're going to discharge them for no therapy, you're sort of at the end of the road, you're an outpatient, write them for the reviewer. Write them for the therapist that might be looking at these notes in a few months because the patient's complaining that they haven't reached their goal. All of that's really important. Pediatric settings, the discharge and discontinuation may include additional factors, the transition to being in the classroom without these services, and finally, the transition plan to discontinue PT services needs to be collaborative. Say that 3 times fast. If you're in the school system, you're with the teacher, the parent. If you're in skilled care, with nursing and the physician or the nurse practitioner who's ever following that patient, the family's involved as well, to make sure that everyone's expectations have been met and that those relevant parties know where to go next with this patient after they're done with the physical therapy plan of care that you're working on. Visit documentation. So now this is kind of going down to the micro level. We've looked at the big picture. We've looked at the plan of care. We've looked at the overall. What does each visit note look like? So your daily note or treatment encounter note, it needs to be sequential. As I've previously mentioned, when someone else is looking at your entire plan of care on a retrospective basis, do these visit notes make sense? Does it include any changes that have happened? The description and progressions of specific interventions. Are you using a flow sheet format, online documentation? Does it include a patient caregiver report? Does it include the interventions you used on the day of that visit? Frequency, intensity, time, duration. All of that needs to be included in your daily note. What was the patient's response to the treatment? Any communication, collaboration with other providers that happened on the day of that treatment regarding this patient, they need to be in this visit note. And factors that modify the frequency or intensity of the intervention and progression within the plan of care, and plan for the next visit. When are you seeing this patient again? Are they coming in 2 days? Are they coming in a week, which is unlikely? Or are we at discharge? Every visit note needs to have the information for when the next visit is, when the next visit's been scheduled. Sometimes patients have vacation. So especially if you're an outpatient, you might say, patient has a scheduled vacation, they'll be returning in 10 days. That needs to be in your visit note. Discharge discontinuation summary. So this is one of those trivia questions. When I used to have large groups, I'd say, who can write the discharge summary, discharge plan? And people would always say the PTA, but that's not true in the documentation guideline. This needs to be written by the physical therapist because it's like an evaluation. It's done at the end, and it includes recommendations for future care. A PTA can't make that, only the PT. So you're summarizing the patient-client's progress towards the goal. Have they met those goals? Have they not? Their status at time of discharge, and future plans for self-management. So this is your big summary. This is your ta-da moment if you're the physical therapist. I designed this plan of care, did the visit, and now look at how much better this patient is. They're ready to go back and play golf. They're ready to go back and drive. They're going home. They can do their ADLs independently. Whatever it is that this patient has attained in therapy, this is your moment to really shine and write that in. The second point here, it's the position of the APTA in many state policies. So for this exam, even if your state allows the PTA to write the discharge plan, it's the PTA that needs to write it because it occurs based on your recommendation, the PT's recommendation, the analysis of their achievements and predicted goals. And that's why it has to be done by the PT. And you look at the third point here. All of those points are PT decisions. Their status, the attainment of goals that have not been attained, recommendations and instructions for future care. Those are not components that are within the physical therapist assistant scope of practice. They are within the physical therapist scope of practice. If they're going to another level of service, the fourth point, from acute to home health, for example, documentation of the coordination with other disciplines needs to be included. Any issues regarding patient compliance? Is this a patient that refuses care 2 days out of 3? Or have you figured out that when you walk into this patient's room, they always say they're tired, they always say they're sick, they always have an excuse. You'll meet this patient, trust me. But you figured out how to get them to work for you. And you want to share those ideas with the next therapist. This is your opportunity to share those ideas. Patient always says they are hungry. Well, schedule your therapy right after a meal. Just put them that spot in the schedule so they can't say they're hungry. I'm tired. Well, let's try to do a little bit and then you can take a nap. And sometimes that works, sometimes that doesn't work. But if you found something that works, put it in the notes for the next therapist. They will thank you. Just like you'll thank them if you're that next therapist and you read in the previous documentation what can happen to get this patient to actually do the therapy for you. So that pretty much, let me go back here for a second. So that pretty much finishes our review of documentation. And I'm looking here, are there any questions on that before I go to the next section of tonight's lecture? I'll wait here for a second. I don't see any questions yet. You can always ask them at the end. Let me give you a few moments here. Okay, if any questions pop up, I'll answer them at the end. But for now, I'll continue. And we're going to get into the more legal components of tonight. Patient rights. So we have the ADA, the IDEA, and HIPAA. Americans with Disabilities Act, HIPAA, pretty straightforward, but these are components that are on the National Physical Therapist exam. Maybe one question, maybe two questions, not 10. But it's important to know what these are, particularly if you're not educated in the United States. These will be new to you, and it's important to have an understanding of these. Over the years, we've worked with many people who've scored 590 or higher, 74 or higher in a few states, and it's that 1 point. And anything you can do to just sort of tighten up these smaller areas that have 1 point here and 1 point there, they can be the difference between passing and failing. Americans with Disabilities Act. This act is over 15 years old at this point. It was originally passed in 1990. It asserts that individuals with disabilities share the same rights as all other individuals to have access to and opportunities for full economic, social, and personal development. As a PT or PTA, you are expected to advocate for full inclusion of people with disabilities in all aspects of community life and within the profession. The ADA, and this is where your questions are going to be, it prohibits discrimination on the basis of disability in employment, state and local government, public accommodations, commercial facilities, transportation, and telecommunications. Applies to Congress as well. Where we've seen this come up in practice questions, in discussions at conferences, has been dealing with or working with patients, clients that have disabilities. And how do you make the physical therapy program accessible to them? You have a patient who's hearing impaired, finding sign language interpreters, patients that have vision issues. So not necessarily functional issues that they're actually receiving therapy for, but other disabilities that make it difficult for them to communicate with you. Communication has come up as definitely one of those areas that the examiners want to make sure that you, as a PT or PTA, understand that when someone can't hear you, that doesn't mean you ask their caregiver the questions whether or not they want therapy or not. Or you're not doing things you're not asking questions of a third party to give you answers when you should be communicating with the patient. Do it through writing. If you don't have a sign language interpreter, write out the question for the patient. If they don't have their glasses and they can't see something, do your best to explain what you're doing so they can see, so they can visualize what you're doing. They can't see, but they can visualize it. So those are your obligations as a physical therapist to make the therapy accessible to the patient. Discrimination in employment, the third point here, it prohibits discrimination in employment, state and local government, public accommodation. We already read that. And then finally, the fourth point, to be protected by the ADA, you have to have a disability or have a relationship or association with an individual with a disability. An individual with a disability is defined by the ADA as a person who has a physical or mental impairment that substantially limits one or more major life activities, a person who has a history or record of such an impairment, or a person who is perceived by others as having such an impairment. The ADA does not specifically name all the impairments that are covered. So an example that's come up in discussion at conferences has been individuals with alcoholism or drug abuse. And is that a disability under the ADA? And the answer is to some extent, yes. And is it your obligation to design a program or design a schedule that works with that person's disability? And the answer is yes. So be aware of that it's not just the disability that you perceive, it might be a disability that you don't perceive. ADA Title I employment. So Title I requires employers with 15 or more employees to provide qualified individuals with disabilities an equal opportunity to benefit from the full range of employment-related opportunities available to others. So you cannot discriminate in your recruitment process, hiring, promotions, training, pay, social activities, and other privileges of employment. It restricts questions that can be asked about an applicant's disability before a job offer is made, and it requires that employers make reasonable accommodation to the known physical or mental limitations of otherwise qualified individuals with disabilities, unless it results in an undue hardship. So if you have 15 employees, ADA applies. For purposes of this exam, be aware of that. Title II covers all activities of state and local government, regardless of the government entity's size or receipt of federal funding. Title II requires that state and local governments give people with disabilities an equal opportunity to benefit from all of their programs, services, and activities: education, employment, transportation, recreation, healthcare, social services, courts, votings, and town meetings. State and local governments are required to follow specific architectural standards, and that's where we're headed, in new construction and alteration of their buildings. They also must relocate programs or otherwise provide access in inaccessible older buildings and communicate effectively with people who have hearing, vision, or speech disabilities. Public entities are not required to take action that would result in undue financial and administrative burden. They are required to make reasonable modifications to policies, practices, and procedures when necessary to avoid discrimination, unless they can demonstrate that doing so would be fundamentally alter the nature of the service, program, or activities being provided. So I think a great question on the exam would be, you're working with a state agency to put in ramps in an older building that had been previously grandfathered from an ADA standpoint, but now that they're doing a rehabilitation of the building, they have to make the building ADA compliant. And you would be working with them as a consultant for ramps and other door widths, other elements that make that building accessible. That would, I think, would be a great ADA-related question on both exams. The IDA. These are a series of laws that ensure services are provided to children with disabilities. The IDA governs how state and local public agencies provide early intervention, special education, and related services to more than 6.5 million eligible infants, toddlers, children, and youth with disabilities. So there's a couple parts to this. So Part C covers infants and toddlers with disabilities, so birth through 2. This is the newest component of this series of laws, and it allows for early intervention programs as soon as a child is identified with a possible disability. There is federal money that comes into play that's distributed to the states to provide these early intervention programs, because it's been recognized that the earlier that infants and toddlers get services, get physical therapy, occupational therapy, speech therapy, the better the outcomes will be. Part B covers essentially school-aged children, 3 to 21. And it's your more traditional special education services and related services. PT is one of the related services, which is done under the IEP. Physical therapists are members of the multidisciplinary school team that ensures a free and appropriate education for students with disabilities to prepare them for further education, employment, and independent living. So the leader of this team of the school-age child is the classroom teacher. But the classroom teacher works with others, the social workers, all of the other disciplines, to ensure the child's success in the classroom, in turn show the child's or improve the child's opportunity for success in life. Using their unique expertise in movement and function, particularly related to the neuromuscular and musculoskeletal systems. The school-based PT promotes motor development, and the students participation in everyday routines and activities that are part of the educational program. Now, here's where school physical therapy is very different from any other area of physical therapy. Everywhere else in physical therapy practice, the point is rehabilitation. You have an injury, you have rehabilitation, you have an outcome. School physical therapy is much more long-term. It is age birth, essentially, to 21 for some students, because you're worried about life. And the physical therapist is not there to make the child better, to rehab a particular injury. If a child breaks their leg, they don't necessarily have an IEP. They go to physical therapy, they go to the hospital, they might have home health, but most likely outpatient physical therapy for the rehab. They're not going to get that rehab in the school system. But if you have a child who's had a more serious injury or a disease that now that impairs their movement, and you have to you have to show the child how to navigate the building in a wheelchair, that would be what a school-based physical therapist does, is help them transport and ambulate or move around the building independently using a wheelchair, using a walker, using crutches, using any type of assistive device so that they can participate fully in the education program. Working with physical education teachers to adapt physical education programs to this student's disability or limitation. So that's where things are different. So under both parts, so sort of coming back to the school system, Part C and Part B, the PT performs therapeutic intervention, including compression, remediation, and prevention strategies and adaptations, focusing on functional mobility and safe, effective access and participation in activities and routines in the natural learning environment. It's all about school. It's all about academics at this level, not the same focus as in every other area of physical therapy. OSHA. So OSHA is about patient safety. It's also about therapist and healthcare worker safety. So whereas safe patient handling refers to policy programs that enable healthcare workers to move patients and clients in a way that does not cause injury or strain, the Occupational Safety and Health Administration, OSHA, recommends that manual lifting of patients be minimized in all cases and eliminated when feasible, and that employers should put an effective ergonomics process in place that provides management, involves employees, identifies problems, implants solutions, addresses injury reports, provides training, and evaluates ergonomic efforts. So, whereas physical therapists and physical therapist assistants are experts in concepts involving rehabilitation and prevention of injury and strain to the neuromusculoskeletal system, fall prevention and utilization technology to facilitate optimal patient outcomes while maintaining patient safety and caregiver safety. So what does this all mean? It means if a patient is of any type of size, you get someone to help you lift them. If you can utilize any type of mechanical lift, you should. If you have patients with max assist. If the patient can help you with this transfer, again, they should. And it's about common sense, but it's also about not lifting any more than you can. Many therapists end up on disability because they've lifted too much back injuries. And that's a real important concern as you're early in your career, to make sure that you always take proper precautions, especially with lifting, to ensure your safety. And that's where I think the question is on the exam. So in answering these questions, follow these guidelines. If you see these questions on either exam, PTs need to have the clinical anatomy to apply safe patient handling concepts when most appropriate based on patient-client presentation. What is the size of the patient? What is your size? Back in our old live course days, I would always say, okay, who's the largest person in this class? There would always be some big guy, 6'2", 250, and then there would always be a woman, not 6'2", maybe 4'10", 95. Who that larger person can lift is very different than who that smaller person can lift. And it's about being smart in that lifting process. Assistants need to have the ability to apply problem solving during patient care to incorporate appropriate safe patient handling concepts. I really think this question could be almost the same on both exams, because the assistants, the physical therapist can have the same problem, but it's the assistants who are more often put in a situation where they might have to lift someone a little too heavy. And knowing those workarounds, using sliding boards, for example, for transfers, to avoid actually lifting is almost more important for the PTA than the PT. Both PTs and PTAs should have appropriate access to a variety of safe patient handling equipment in their practice, and your department should have appropriate policies and training in safe patient handling procedures. And it's also, I think, a great question about how to design a program for CNAs and other support staff in hospitals and skilled care facilities, as well as school systems, because physical therapists, as the doctor of physical therapy, very much are a leader in this type of education for other healthcare professionals. HIPAA. 1996, Congress passed the Health Information Portability and Accounting Act, mandating the adoption of federal privacy protections for individually identifiable health information. Everybody complies with HIPAA at this point, and even back in 97, people did. Any PT entity must have in place appropriate administrative, technical, and physical safeguards that limit incidental uses and disclosures. But the law is practical. That's a good thing. And recognizes that the entity does not have to guarantee the privacy of protected health information from any and all potential risks, and further recognizes that oral communications often must occur freely and quickly in treatment settings. So while you still see in hospitals little signs in elevators, remember, elevators are public places, they recognize that you have to communicate at nurses' stations. You have to communicate in the therapy room. There might be other patients. But they also recognize that for very sensitive communications, you're going to go into a private room. Nowadays, most of the action is in computer security. Are your medical records confidential? Could some hacker get in there and get the medical information, which I don't really think there's much use to some garden variety hacker and who's diabetic and who has cancer, but I do think there's a variety of your overall health systems of people's social security numbers and insurance numbers, and that's what needs to be protected and safeguarded. So what are reasonable safeguards? Speaking quietly when discussing a patient condition in the waiting room with family. Avoid using the patient's full name in public hallways, locking file cabinets or record rooms, and providing additional passwords on computers. Most online systems now require you to change your password at a stated interval. Yes, that means memorizing your password is harder. You can't use the word password as your password, but it's all about patient privacy and security. A facility does not need private rooms or soundproof walls to avoid a possibility that a conversation would be overheard. If where multiple patient physical therapist communications routinely occur, cubicles, dividers, shields, or curtains could be a reasonable safeguard. Many physical practices have gyms where several patients receive exercise therapy at the same time. This is fine as long as detailed discussions of treatment in progress are done in a more private setting like behind a room divider. So when you see these outpatient physical therapy clinics which have one big room, one big gym, that's fine from a HIPAA standpoint. Parents, got to have some parents in here, as personal representatives of unemancipated minors. This is one of those quirks that we think would make for great questions on both the PT and PTA exam. Interesting, HIPAA specifies 3 circumstances in which the parent is not the personal representative with respect to certain information about the minor. In these situations, the parent does not control the healthcare decisions and thus does not control the information. These occur when, number 1, state or other law does not require the consent of a parent or other person before a minor can obtain a particular healthcare service and the minor consents to the healthcare service. So there are certain state laws that allow minors to get certain healthcare services, such as mental health treatment, without the parent's consent. So it's not 100% of the time. When a court determines someone other than the parents makes the decision, so that oftentimes that's mental health, this may not be that much of a physical therapy situation, but you need to know that it's out there. And when a parent agrees to a confidential relationship between the minor and the physician. So this slide has had some changes. In the old lives course days, I would ask the question, can a 16-year-old ask for a copy of their medical record? And everyone would say, no, it has to go to the parents. Actually, a patient who's 16, who is considered a mature minor, can ask for a copy of their medical record. As you know, I have an 11-year-old right now. If she asks for a medical record, don't give it to her. I don't consider her mature. You shouldn't consider her mature. No one should consider her mature. She's 11. But a lot happens between 11 and 13 with children. One of my girlfriends, she's not in healthcare, she said, it will be one day. One day you go from this little girl, lollipops and unicorns and fairy princesses, to wanting to decide where she's going to college and deciding to get married. I'm not sure it's that fast, but it does seem to be pretty fast between those ages. And you as a physical therapist, when you have someone who is in those, 12 and over is generally considered the judgment. But not every 12-year-old's ready. It's your judgment who's a mature minor. So if a 13-year-old who's still unicorns and fairy princesses asks for their medical record, you can say, I don't consider this patient mature, and not give it to them. But once you get a little older, the 14s, the 15s, the 16s, they are mature. And if they seem to understand what they're asking for and what it's all about, you can give them a copy of their medical record. You don't have to have the parent's signature to give a child a copy of a medical record. So I've always thought that this was a really ripe area for questions. I don't know if there have ever been any questions on it, but I consider it pretty ripe. That's all, folks. This will get posted online. You should get a copy of this. I see we have some pretty good attendance tonight. Thank you for showing up. I appreciate it. And if you're listening to this afterwards and you weren't able to show up, thank you for listening. I'm going to take a few moments for any questions on documentation, the legal concerns that we covered tonight. These are not a ton of questions on the exam, but there's definitely enough questions that if you've got a 596 last time or a 74, it's good to know these areas. I'm going to wait here for questions. Oh, I got a hand. Sorry, Phil's had it. I'm sorry. You've had your hand up for a while, and I'm just seeing it, Phil. Let me unmute you. Yeah, okay, Phil, you're on.
I just want to know what is the exact job of the MDS function for a skilled care facility?
The MDS, the minimum data set, is a very long document. Nowadays they're all on computer, but back in the paper pencil day, they would be about 8 pages. And they were an assessment done by nursing, coordinated by nursing, with the input of the other disciplines, such as physical therapy for where it was relevant, occupational therapy where it's relevant, dietary where it's relevant. So pretty much all the disciplines in a skilled care facility as to the functional level and the needs of the patient. So an MDS for where the physical therapist would be concerned might include transfer skills. Is this patient upon admission independent in transferring from the bed to a wheelchair, bed to a walker, independent in toileting activities? Do they use a toilet chair, bedside commode? That would be, are they independent in getting to and from that commode, for example? Those would be components of the MDS that relate to the physical therapy skills. But nursing pretty much oversees it. Nursing oversees the updates to it on a regular basis. And this is another way for nursing, the director of nursing, to track the functional level of all the patients in the facility throughout their stay, whether they're a short-term resident or a long-term resident. Does that answer your question?
Absolutely, thank you.
No problem. Any other questions here? I'll give it another moment or two. Okay, I don't see any other questions. If you have any other questions via email, my email is maryluski, and actually, send it to that one. Maryluski, MARYLUSKI @yahoo.com, and I'll try to answer it. And thank you for coming tonight. This will get published, if not tonight, tomorrow morning for viewing by you and the rest of your class. If any of you are PTAs and you're taking your test, please, good luck, relax. You've prepared well, and you're going to rock. Thank you, and everyone have a great night. Bye.